Okay, I'll go ahead and get started. Again, for those of you just settling in, my name is Leanne Foster, and I am a member of the Provider Outreach and Education team here at WPS. And I'd like to welcome you all to our For the Love of Telehealth E&M Services Part 1 of 2. This is a two-part series that Ashley Dakota and myself are doing. Today's session is Part 1. And we're going to focus on the updates for telehealth in 2026. We recognize that there's been a lot of changes. There's been lots of stops and starts to flexibilities. And today we've timed this session specifically for the end of February so that we can incorporate all of those into the session. Now today we're focusing on all of those changes. Tomorrow Ashley is going to be doing the second part of our series, which is going to focus on denials and rejections specific to services that are submitted as telehealth. It's also going to include the opportunity for you to apply your knowledge from today. There's going to be an interactive activity that's going to help you just make sure that you have the information you learned today ingrained and make sure that you have a full understanding. So the registration is still open for that. If you have not registered and you are interested, I have asked Ashley to place a link in the chat for that, and that'll be coming shortly. So today's objective, as I mentioned, it is to provide an understanding of telehealth coverage for non-behavioral health services. I just want to call this out because what we have seen is there's been some differences in the extensions and what has been made permanent for telehealth related to mental and behavioral health and non-behavioral health. So what we have done is we are separating the two. Today is focused on E&M services that are non-behavioral health. On March 19th, our colleague Karen Curtis and Mary Muko are going to be presenting a session specific to mental and behavioral health. So if you're interested in that, the registration is still available for that, and that registration link has also been placed in the agenda. So for non-behavioral health services, how are we going to provide this better understanding? So we're going to do that by going through telehealth coverage and billing requirements, including those flexibilities. We are going to talk about originating and distant sites. We are going to talk about technology requirements, and we are also including today provider enrollment scenarios. I know that has something that's been changing and adjusting throughout this, and so we're going to talk through what those requirements are, because with telehealth we recognize often organizations are using providers that are not necessarily right there in their office. Like I said, we are talking about those flexibilities. They have been extended by recent congressional action, and we'll get into that and what those flexibilities and those extensions are. And then we are also going to spend some time talking about how to locate telehealth eligible codes. We did get a lot of questions about specific procedure codes, so we're going to show you how to find out if a procedure code is indeed eligible to be billed for telehealth. So I'm going to start with a telehealth overview. So many of you are already billing telehealth, but for those of you that may be newer to telehealth, I just want to level set. So telehealth is a substitute for an in-person visit that is allowed for certain healthcare services, so that versus having that patient come into the office, they can receive that service via telehealth. So not only can this be more convenient for the patient, it can also ensure better access to care and improved outcomes for the patients. It also reduces the cost of care. With that access to care, I just want to point out you may have beneficiaries or patients that are unable to travel to the office that may forego that care unless that service were offered via telehealth. So this is a benefit that that really does benefit both the program and the beneficiaries. Now it does replace a face-to-face visit. So again, it's going to be the same services that would be provided in office, just in a different modality. We will talk about this a little bit more, but we often get asked about the coding for this. We are not utilizing special codes for your typical office visits. You're just billing them slightly differently, but utilizing those same codes. It's replacing those inpatient visits. Also want to talk just a little bit about the technology. It's an interactive technology. Now there are some flexibilities in place for this, and we will get to those in a minute. But that interactive technology, what CMS means by that is audio and video. So let's just talk about the flexibilities right off the bat. This is probably the biggest question that we got in our pre-submitted questions for this session. So the flexibilities were slated to expire or did expire on January 30th of 2026. However, due to congressional action through that Consolidated Appropriations Act of 2026, which I have included a link for in your training material today, they did extend flexibilities until December 31st of 2027. This occurred on February 4th. So I just want to repeat that. Flexibilities have been extended until December 31st of 2027. These flexibilities include the geographic location restrictions, which we'll talk about. The practitioner types, those expanded practitioner types are still in place. It's also extended the use of FQHCs and RHCs as distant sites for telehealth services. It's also extended audio-only services. And we'll talk about all of that in a little bit more detail. But I do want to address one question that we did get quite often in our registration questions. We did receive the question about when these services, or if CMS is considering making these flexibilities permanent. As you can see, those flexibilities have been extended. MACs are taking their direction from CMS and Congress, and this is what we know to be the case today. As far as whether or not these telehealth services will be made permanent, we do not know for certain if that is something that they're discussing or if that's something that will happen. We understand that all of the stops and starts have been made things a little bit challenging and a little bit confusing. If that extension is changed, or if these are made permanent, we will certainly make sure that we are communicating that and providing education to help support you through this, because again, we understand that this has been a little bit of confusion. So next I want to talk about the eligibility requirements for telehealth. So first and foremost, the beneficiary has to be a Medicare eligible beneficiary in order to bill Medicare. That's with any service. The service also has to be medically necessary per the Social Security Act of 1862. So we need to make, or 1962, sorry, we need to make sure that that information, or that the service is needed for that patient. It also has to be a service that is covered by Medicare. This means that it cannot be something that is statutorily excluded. And we are going to show you where those telehealth services are, because it does also have to be an approved telehealth service. But that statutory exclusion, or whether or not it's a covered code by Medicare, you're going to want to check those RVU files just to see if it is a valid code for Medicare. CPT and Medicare do not always align on what codes are valid, and we'll talk a little bit more with that with audio-only services. Sorry, slide got stuck there. So let's jump into telehealth services. As I said, it has to be a valid telehealth service. So not every service that Medicare pays for is necessarily something that can happen via telehealth. CMS determines which services that they're going to allow to be payable as a telehealth service, and they maintain that list on their CMS website. So we will go out to that in just a moment, but that list is updated yearly. It was updated in November of 2025, so that has been updated recently. They do maintain an archived list as well. There are sometimes changes. There might be a code that was there last year that's not there this year, and none specifically come to mind, but it is something, you want to make sure that you're checking this list when it's updated, because this service may not always be via telehealth. Now, when you look at that list, you are going to see a proposed action column, and that proposed action column will say if it is something that's been maintained from the previous list or if it's an addition. It's not going to show the removed codes. So I've included a link here, but I'm going to show you how to access that from the CMS website. So here I'm just on the cms.gov website. I typically do searches. And just a hint, right now telehealth is such a hot topic. it is something that is going to show up the second that you click into that search field on their website, on their homepage. So I'm just going to click on telehealth. You get the same results if you search for that word. Now there's a couple of different things that come up, telehealth and list of telehealth services. This telehealth is something that's going to contain a lot of resources, including that FAQ, but our focus is going to be on this list of telehealth services. If you go to the CMS telehealth site, you will still have a link for these services. This is just a more direct way to get there. So on this page, you're going to see a couple of things. One, you're going to see a link to the physician fee schedule. This is going to give you information about reimbursement amount. The reimbursement amount is not different if that service is provided via telehealth versus in person. We just need to know how it was rendered, telehealth or in person. And then here is the zip file. This is the list for telehealth services. I'll take just a minute to open up. There we go. So that opens up as a zip file. There's going to be two files. There's a text file and there is an Excel file. I'm going to open up that Excel file. They contain the same information. It just depends on how you would like to pull that up. So this is what that list looks like. So first it's going to tell you the calendar year that it's for, and then it is going to have the list of codes. So as you can see, and I'm just going to, yeah, it's an expansive list of services that are provided. It is something though you are going to, as I said, going to need to check when it's updated. Something that was telehealth may not always be telehealth. I have not experienced them removing a lot of codes from telehealth. More so I have experienced them adding them. But it's going to be the code. This will include HCPCS and CPT codes. We got a lot of questions about G codes. You'd want to search here for that G code. If that G code is on this list, it is covered as telehealth. We did get some questions about audio-only codes, which we'll talk about. For instance, there are codes that CPT and the AMA have that are specific to audio-only services. Those codes are not on this list because they are not a recognized Medicare code, and we'll talk about that in a moment. It'll give you a short descriptor and then it'll tell you the proposed action, again, that maintain or that addition. But this is going to be your primary resource for, can I do this service via telehealth or not? If it's on the list, you can. If it's not on the list, it is not covered as a telehealth service. Also, if you're not seeing a code that you believe should be covered or considered for telehealth, you can actually request that CMS add it. Now this is something that would go under review, but there is a link here for requests for additions. And what that does is it takes you to the instructions for requesting those. It tells you what information is needed, what evidence is needed in order to support the request, and then it does give you a link to the mailbox. But right now they are showing that no later than February 10. But in the future, if you'd like to submit those, you can. And it's just a timing for consideration. You can always send that in. It's just a matter of timing for consideration. But this is where you would go if you needed to request something. They also provide information on the review criteria and what they're looking for. So again, just some resources to consider. Next, I want to talk about eligible practitioners, and this is where we are going to see some of our extensions kick in. So the services must be within the practitioner's scope of practice for their state. We did get some questions about licensure, but really that is at the state level. CMS does not control that. So if they're providing a service that their state where they're providing that service indicates is in their scope of practice, then they can provide that service. Now, typically, permanently, we have physicians and non-physician practitioners. There were some flexibilities extended for physical therapists, occupational therapists, speech and language pathologists, audiologists, dietitians. Those flexibilities were set to expire on January 1st of January 30th of 2026. However, those have been extended until December 31st of 2027. So those providers can continue to provide telehealth services until that extension expires in 2027. This is something that is also outlined, and I'll reference this a few times today. There is an FAQ, and this has been updated. And what I did, I just went to telehealth and I went to that telehealth FAQ. This was updated in mid-February of 2026. It was updated a little bit before that as well. They've had to make some adjustments. But this is going to be a really good resource that's going to talk about those extensions and what is still allowed. In fact, the second question is about the restrictions on types of practitioners. They're going to have to be enrolled in Medicare. They're going to have proper licensure, but the expanded eligible practitioners has been extended. Next, I want to talk about technology requirements. Now, typically, telehealth requires two-way interactive audio video. So meaning you can see and hear the patient. However, there are going to be times where the patient either cannot do that two-way interactive audio video or would prefer not to, and they're refusing to do so. At that point, permanently, you can provide audio only services, but you'll need a modifier 93 to tell us that that is an audio only service. And we'll talk about those modifiers later on, so we'll talk about that again. The technology has to be HIPAA compliant, and the patient does have to consent to receive those services. So that's the technology requirement. Now there is a flexibility here as well. Audio only services. This is where you'll start seeing some differences for non-behavioral health and behavioral health. I'm not going to get into the behavioral health other than I can tell you the audio only has been made permanent there. For non-behavioral health, it is a flexibility. Again, extended until the end of 2027, but audio only is a valid modality for telehealth. Again, we'll talk about this here, is that it's not going to be a different code. We did get a lot of questions, and I'm starting from the bottom of my slide here, but we did get questions about the CPT codes that are specific to audio only, and the 98,000 through 98,015. Those are invalid codes for Medicare. They are audio only telehealth codes. However, they're not utilized for Medicare. They may be used for other payers. They may even be utilized for the Medicare Advantage plans, but I cannot speak to those plans because we are MAC for traditional Medicare, and the MA plans may follow slightly different billing procedures for their services. So you'd need to check with those other plans if they're recognizing those codes. But for Medicare, you would use your normal E&M codes for the service that you're rendering as if you were rendering that service in office. You're just going to bill it as telehealth. So use that appropriate code. If it is audio only, as I mentioned, you would use 93 to let us know that it's audio only. For RHCs and FQHCs, you are going to use the FQ modifier. It's just slightly different, so you want to make sure that you're cognizant of that when you're billing. Next are the geographic restrictions. Now, typically for telehealth, in order to provide those services, you do need to be in a HPSA or an MSA, which is a metropolitan statistical area. You have to be in some type of healthcare shortage area in order to provide those telehealth services. However, this is an extension that has also been renewed until the end of 2027. So the geographic location restrictions do not apply until 12/31 of 2027. So any geographic location is eligible to utilize telehealth services. So with that, we do need to talk a little bit about originating and distant site. So first we'll talk about the originating site. Now the originating site is specific to telehealth, and this is the location of the patient at the time the service is being being provided. It can be their home and it can be other than their home. When we talk about place of service a little bit later, that's what's going to tell us. Are they in their home receiving the service, or are they someplace else? Someplace else, we're going to talk about those examples here in just a minute. As I mentioned, originating site typically has a geographic restriction. However, that flexibility has been temporarily suspended until 2027. It's a little ways out, but we still need to be cognizant of the fact that this is temporary. Now, there are going to be situations where you have a service where the patient is receiving telehealth services in a facility, and at that point that facility can bill for a facility fee. It's kind of like a hosting fee for hosting that service. The provider is maybe providing telehealth from a clinic, but the beneficiary is in the hospital. There is a code for that. It is Q3014, and that is billed for that facility fee. So this isn't going to be the clinics. This will be billed on those UBs. But that Medicare allowance for 2026 is $31.85. But as I said, I do want to reiterate, though, typically this is something that's happening in a geographic area that meets the requirements for telehealth, so usually a pretty rural area or healthcare shortage area. But that has been suspended until the end of 2027. So examples of those, it could be an originating site, could be a physician or practitioner's office. Obviously that facility, that Q code is not going to apply there because it's not a facility. You're going to have hospitals, you're going to have your critical access hospitals, your rural health clinics, your federally qualified health centers, your skilled nursing facilities. You're going to have your mental health facilities and renal and dialysis facilities. They're all going to qualify as an originating site. I do have some acronyms here, and I do want to call out acronyms. If they are not spelled out on that slide, they are in the notes section of the training material that's on our live events page, just making sure that everybody has those. Next, we want to talk about distance sites. So this is the exact opposite. This is going to be where the physician or practitioner or other qualified health professionals located when they provide the service. This could be their office. It could be the practitioner's home. We are going to talk about some of those provider enrollment scenarios here in a few minutes, but it is where that provider is. This is the address that's going into box 32. If you're billing, say, a 1500 and 837p transaction, will be in the appropriate loop for that. Now, the thing with this, the providers must be enrolled in Medicare. That's why we're going to go into some of those scenarios, because again, we recognize that offices and organizations are using providers that may not be located in their geographic area, and CMS has made some allowances for that. So we are going to go through those. But this distance site, this is going to determine the MAC build. So if you have a provider that is seeing a patient in Michigan, they work for a facility that's in Michigan, you're going to be billing Michigan. There may be times where the provider is billing in a state other than where the beneficiary is, because it's about where the provider was when they provided the service. That's how we identify the max billed. With that site also comes virtual supervision. So there have been a lot of questions about this because the 2026 final rule made virtual supervision permanent for certain services that require direct supervision. And direct supervision, we mean immediately available. So think of things like incident to services that require that direct supervision. It now can permanently be carried out through virtual supervision versus a physical presence. Both office, home visits, those types of things. It is going to exclude any services that are either a major or minor surgery. So we're looking at services with that 10 or 90 global indicator. Those are not going to be situations where that virtual supervision is allowed. That was in that 2026 final rule. Where we're getting a lot of questions, though, is about residents and teaching physicians regarding virtual supervision. So CMS makes very clear in that FAQ, and I'm going to go out to that now. So it is question 7 in that FAQ, and it's asking about virtual presence for that. Now, with residents and in the teaching setting, that teaching physician needs to be there for the key and critical components of that service. As far as virtual presence, right now CMS has made it clear in the Medicare Learning Network article on telehealth, along with the FAQ, that virtual supervision is allowed for telehealth services for those residents. What that means is that the resident, the patient, and the provider are all present virtually. What we're getting questions on is if the resident is physically in a location with the teaching physician virtual. At this time, the guidance that we have received from CMS is indicating that that's not going to be allowed because there's not a virtual present. It has to be everybody is in a virtual situation for that visit. Now, we are aware that this is causing some confusion. Other MACs have also reached out to CMS regarding this. They are reviewing that to see if we can get some clarification. But at this time, that virtual supervision of a resident is something that is only available if the entire service is telehealth. So next we're going to talk about provider enrollment and telehealth. Oh, sorry, that slide didn't go. There we go. Pardon the lag on that. So there have been a lot of questions about how to enroll providers appropriately when they are providing telehealth from their home. This has been a big question since the beginning of the flexibilities. How do we enroll them? What do we report? Who do we bill? We're going to get into that, but one thing I want to call out is that we also get questions about licensure. When a provider enrolls in the Medicare program, they are going to need to have appropriate licensure in order to provide services to patients. That licensure can vary widely from state to state. Some states may have reciprocal arrangements where a provider can utilize a license from another state to provide services to their patients. CMS does not control that, and we do not have a blanket requirement for that. Enrollment's going to be looking that the provider is meeting the licensure requirements in the state that they're reporting on their enrollment application. So I want to be very clear on that. What we're talking about is how they're going to bill and where their practice locations are. You need to check with regards to licensure requirements. So with addresses, the big question is, again, when they enroll, do they need to report their home location? That's been the big one. And the answer to that is it kind of depends. It depends on how they're set up, if they have a physical location or if their home address is their only location. So here's what we mean by that. If they have a physical practice location that they are enrolling under, this can happen quite a bit with solo providers. If they have a physical location and they practice from their home address, they have a physical location. They do not need to report that address. You may have a provider who is reassigning benefits to a group or organization that has a physical location. They do not need to report that home address if they're having that home address and that physical location in that same state. Now, if they don't have a physical location, we do recognize there are some providers that are providing services virtual only, and there isn't a physical location. They do need to report their home address, and that is because we cannot enroll a provider without a practice location. We cannot enroll in that practice location. We cannot enroll them with that practice location being virtual. That goes into the claims adjudication system. Now, we do also recognize that offers some issues for privacy, meaning that on our directories, providers are not wanting their home address reported. CMS has made adjustments to both the 855I and the 855B application in Section 4 to help with this. They are going to have options to indicate that the location type is a business office for administrative purposes only or for telehealth, or they can tell us it's a home office for administrative or telehealth only. What that does is it reports the address to us. It puts it in the claim adjudication system so that your claims will process appropriately. However, it suppresses that information from anything public. So their address is in systems that are secure. They are CMS systems, and they do have a very high level of security. So it's not something that's going to be released out to the public. Now, we do also get the question about providers that have already provided their home address and they would like that suppressed. It's not going to automatically suppress. You can submit a change of information application with that section 4 updated with that home address and that checkbox, and then we can get that information taken down from those public sites. So next I want to spend some time on some scenarios because this can get really confusing. It's a little bit like a choose your own adventure book. So this first example is going to be for a provider that is in private practice and does not have any reassignment. So this is a provider that's practicing on their own. They're a solo provider under their social security number or some sort of tax ID. And with this, they are going to be providing telehealth services from their home, in this example, in Kansas. So in this case, they do not have any physical practice locations, but they do need to enroll. When they submit their 855I, because remember they have no reassignments and they are a solo provider, they are going to enroll themselves with that 855I and they are going to indicate that home address, but they're going to check that magic box that is going to suppress that home address from anything public. Their jurisdiction, because they don't have a physical address, all they have to report is the home address, is going to be that home address, in this case Kansas. Claims are going to be billed and paid to the Kansas MAC. The next example is fairly common. This is going to be a provider who's providing telehealth services from their home. In this example, I'm using Michigan, but you can insert state there. But they're providing services from their home. They are reassigning to a group that is also located in Michigan, and they have a physical location in Michigan. Now, their enrollment, they may already be enrolled, so they may not have to do anything. But if they weren't enrolled, what would happen is that group is going to report their physical location on their 855B in Michigan, and they're going to receive that provider transaction access number in Michigan. The individual provider that's only seeing patients from their home is going to submit their 855I, and they are going to reassign to that group in Michigan. The provider does not need to report addresses on that application. It's optional. They're going to fill out in section 4, that reassignment section, telling us that they're joining this group. When someone reassigns to a group, they are getting paid based off of the physical locations on file for their group. They can indicate to us if there are locations they want us to know that they're at, but that is optional. It's not a required section. Again, they're joining a group. They have to follow suit with everything in that group. So what happens there for claims? Claims are going to be submitted to this group. In this case, it's going to be Michigan, and they're going to be paid based off of the group locations. The provider does not have to report their home address. The next scenario, this is going to be where they are reassigning to a group in a different state. This is where we tend to find most of the questions coming in. So in this example, the provider is providing telehealth services from their home in Florida. Now, I made sure that that was not a WPS jurisdictional state for emphasis. So this is going to happen. This is also a common scenario that we see. They are reassigning benefits to a group located in Kansas, and they have a Kansas physical location. So they're in a J5 jurisdiction. The group is there. The group may or may not already be enrolled, just like with the last example. But what's going to happen is the group, because they have that physical location, they're going to enroll that Kansas location, whether at the same time as the member or before if they're an existing group, but they're going to list their Kansas locations. The provider, again, just like the last scenario, is going to submit that CMS 855I, and they're going to reassign to that group in Kansas, and they are not going to report their home address. I do want to reiterate, though, they are going to have proper licensure to be able to provide services to those patients in Kansas. So there may or may not be a reciprocal arrangement with their licensure. That is something you would have to verify with the state licensure, but making sure that they have that information. When this provider in Florida submits their enrollment for Kansas, we are going to be looking for that licensure requirement in Kansas. When they submit claims, the claims are going to be submitted to the MAC for Kansas, so that's WPS, and they are going to be paid based off of the group locations on file. Again, they're reassigning benefits, so as far as location, it is about, in this scenario, where that group has their physical locations. And I hope you're seeing a continuing theme. Basically, if there are physical locations where they're seeing those patients, they can use those addresses and they do not need to report the home address. And this is something that is outlined before I get to the last scenario. This is something that is actually in question 15, pardon the scrolling. Question 15 of the FAQs, where it is talking about, in many cases, they're not going to need to report that home address any longer. Okay, again, it's about, is there a physical address that they can leverage, or do they only have their home address? So then the last scenario that I have from a provider enrollment perspective, we have a situation where the provider is reassigning to a group, but the group doesn't have a physical location. These are those we only see patients from our home scenarios where there isn't a brick and mortar location to report other than their home address. So in this instance, the provider is providing the telehealth services from their home in Indiana. The group does not have a physical location, and you can interchange the states. Again, it's about, is there a physical location for that group? In this case, there isn't one. So here's what's going to have to happen. If the group is wanting to establish their business for this provider that's seeing their patients in Indiana and they don't have a physical location, they're going to have to submit the 855B, and they're going to have to use the provider's home address. And that is, again, because we have to have an address in order to set up a provider and assign that PTAN number. They can select that checkbox that is going to suppress that from anywhere public. It'll only be in CMS systems. And then in turn, that provider is going to have to reassign their benefits to that organization. But the same would be true if the provider were in a solo situation, that first scenario that we had, and they don't have a physical address. They have to report their home address if they do not have any other physical practice address to report. In this situation, they're reporting their home address. The claims are being submitted and paid based off of the provider's home location, not the patient's location. It's where the provider provided services. Much like brick and mortar, it's where the service actually occurred, and that's where the provider is. So next we're going to get into some billing requirements. Now, we did get quite a few questions about place of service. I know that has changed. There's been some combinations of modifiers over these years since COVID, how we're billing and how we're not. So it's really simple. For place of service, we need to know where that patient was. That's the place of service. So you're not going to, if you have a telehealth service, if the patient is somewhere other than their home, they are going to use place of service too. So this could account for if somebody is billing and the patient is, say, in a facility. Now that facility may be able to bill that Q code for hosting that. They can get that facility fee, but it would be too. The patient is somewhere other than their home. If they are in their home, you will use place of service 10. We did get quite a few questions about modifiers. these the place of service here effectively tells us this was a telehealth service. 95 is the modifier that comes up. And we'll talk about that in a minute. 95 isn't required, especially if it's an office service. There are some of the facilities that are billing on the UB04 that will still need to use that just because they don't have place of service on their form or their claim submission. You can put a 95 on a 1500 or an 837P. However, what I mean by that is it's not going to hurt anything. However, it's not needed. It's not going to change the outcome. It won't cause denials, but it's not really telling us. It'll be informational only, and it's extra information because the place of service 2 and 10 is already telling us that. There was a period of time where you needed to use that. We no longer do that. That changed end of 2023, beginning of 2024. So on to modifiers. So with modifiers, audio only. Typically for non-behavioral health services, we're not allowing for those. You certainly are not going to bill the CPT audio only codes. You're using that appropriate code. But because of the flexibilities, modifier 93 is going to tell us that it was audio only. We'll get to documentation here in just a second, but you'll want to document why that was audio only. Patient wouldn't give consent for audio video, didn't have the technology. Just let us know what happened with that. But put in 93, that'll let us know it's telehealth, but it was audio only. It's informational only. Now for RHCs and FQHCs, you want to use FQ on your claims. That's going to tell us the same thing, that it's audio only. 95, like I said, it's not needed for most services. However, for outpatient therapy, where that OT, PT, SLP is employed by the hospital, those are going to be the scenarios where 95 is going to be appropriate. And then GT is used by critical access hospitals that are billing method 2. Sorry, y'all, I had a tickle in my throat. Didn't want you to hear me cough. Okay, next we're going to talk about documentation. Tons of questions about documentation, understandably. Again, things have been pretty mobile. They've moved, they've stopped, they've started, they've been suspended, all of this. So certainly everyone wants to get this right. So from a documentation perspective, you're going to document a telehealth service the same way you would bill any other in-office service. So you're going to document why it was medically necessary. You're going to document what happened in the encounter. What were the problems addressed? What did you do for the patient? All of those same documentation principles apply. As far as telehealth, you do want to document that the service was delivered telehealth. However, while you need to show that it was delivered by telehealth, what that does is it supports that place of service 2 and 10. There doesn't necessarily need to be a reason given, but just that it was delivered telehealth versus office. You're going to want to show their consent. However, as far as verbiage, if we're looking for something like a blanket statement or something very specific, CMS has not provided specific language. So how you document that this was telehealth versus in-person is going to be a business decision, but it does not have to be a complicated one. Again, just telling us that this was telehealth and why. If it was audio only, why was it audio only? Just so that it is supporting the claim that's billed if it comes into review. One thing about that consent, it can be verbal or written, but it does need to be documented. If it's not documented, we don't know that it happened. That's true with most documentation. We're not wanting necessarily a novel, but it has to be clear enough to a reviewer so they understand what happened. So here, I just want to, before I check in with questions and give you a few resources here, I just want to give you a reminder. I've mentioned this a few times, but the flexibilities were scheduled to expire the end of January 2026. However, on February 4th, so they did make the flexibilities retroactive, but on February 4th is when that Consolidated Appropriations Act of 2026 was signed into law, and that extends the flexibilities that we have been operating under for quite some time until December 31st of 2027. And again, this is non-behavioral health. Again, I encourage you to check out that mental health telehealth session that we're offering on 319, because there are some things for mental health that have been made permanent, and some of those flexibilities are the same ones that are temporary for non-behavioral health. So non-behavioral health, to recap, the flexibilities that go until 2027 are geographic location restrictions. So that rural area, that HIPSA or the MSA area requirement, that's a flexibility that's been extended. So that's not something that will apply until the end of 2027. Practitioner type, the expanded practitioner types that includes those occupational therapists, physical therapists, the speech therapist, that has all been extended until the end of 2027. FQHC and RHC for telehealth services, that has also been extended. One thing that I do want to point out there that I didn't before is the resource that is out on the HHS.gov, and this is included in your training materials in the resource section. This is going to be a valuable resource in addition to the FAQs. And if you go into that site, billing for telehealth, and then you get to billing Medicare as a safety net provider, there's actually telehealth policies that are specific just to the RHCs and the FQHCs. So this will also include your revenue codes and reimbursement rates. So if you haven't found this yet or checked this out yet, this is a useful resource that I would encourage you to check out. And then the last flexibility that I want to talk about are those audio-only services. They are typically not something that is allowed, but there's a flexibility through 2027 that allows services to be audio only. The quirk here is that what is permanent is that the provider has the ability to do audio video, but the patient refuses or cannot do it. That's documented, but that's something that is not expected to go away. Audio only without that, just audio only, both on the part of the provider and the patient, that is something that has been extended. But again, I've seen a couple of questions. You need to document that, and you're going to use that modifier 93. Just making it abundantly clear to a reviewer what happened. You've done the work. We want you to get reimbursed for it. We want to make sure those pieces are in place. So here I have included some great resources for telehealth. The first one is to the Consolidated Appropriations Act, gives a little bit more background into what's been extended, and it gives the details we've given today. The Medicare Learning Network article for telehealth services that has been updated. As I mentioned before, though, there's some discrepancies. There's been some feedback given that, I don't want to say discrepancies, but they may not be giving the same message, and CMS is aware of that, and they are looking at that, so there may be some updates. Just stay tuned. But the FAQ is here as well. That is something that is going to be very helpful to you, and hopefully will answer a lot of your questions that you may come upon. Also, I've included the link to the Medicare Claims Processing Manual, Chapter 12, Section 190.3. This is the section of the manual that covers telehealth services. One caveat, this does not have the flexibilities manualized, and they won't. They're temporary, they're flexibilities, they have an expiration date. You'll need to use them in conjunction. Chapter 12 is going to talk about the geographic restrictions, because typically they are in place. The flexibilities will be what we're following. And then I took you to the telehealth hhs.gov. That's that resource that has all of the flexibilities laid out. and that'll be a useful resource. And then the physician compare, that last one, that is that provider directory. If you have a provider who's reported a home address and you're unsure if it's been suppressed or not, that's the list that you want to look at. And remember, that can be adjusted through those as an enrollment application change to get that suppressed. Okay, we have a little bit of time for questions, so I am going to check in with Ashley. Ashley, what questions do we have in the chat?
All right, we have a lot of questions. I've gotten most of them answered, so we have just a handful yet that do not have an answer. The first one is, one moment. Does CMS require the provider to be credentialed in a HOPD where the patient is located if they provide telehealth from a distant physician or practitioner office?
Sorry, I was on mute. So they need to be enrolled in Medicare. They don't necessarily need to be in the same facility where the patient is, because we understand they may be reaching out to various specialties, but they're going to need to be enrolled, and they're going to need to bill appropriately for how they're enrolled. Next question.
Our next question is, and this question, Leanne, was a follow-up. We had a question previously asking about the consult codes, G0425 through G0427, and they're asking if a provider can choose between these or traditional codes 99221 through 99223 with place of service O2, or if they're required to use the G codes.
So if memory serves, those are going to be the consult codes for the emergency rooms, and you're going to have to build a code that's appropriate for the service. So it's going to depend on what's happening for that patient and if that code is appropriate for what was provided.
And one more on my list as of right now before I scroll down. This one is to confirm then there does not need to be a time statement if the video was not able to be done via video.
We wouldn't be looking for time. We're just looking, not sure what type of time statement you're asking about, but we don't need to have a time statement as far as the video. Now, if you're billing the service based on amount of time, we're going to need, versus medical decision making, we're going to need to know the time. Again, depends on the type of service. If it requires a certain length of time to bill, then we would need it, but it's not related to that audio video. Ashley, while you scroll down, I do have one other thing I want to throw on the chat, y'all. I see a couple of questions towards the end asking about ESRD. Now, billing for that just has a couple of differences, and the biggest one we think we're being asked about is a face-to-face assessment, the face-to-face elements. So ESRD, that dialysis, it still needs that face-to-face assessment for the first 3 months and then once every 3 months thereafter. That requirement's not been impacted by the flexibilities, and we do have a couple of resources that I want to put in the chat for you here. So those will be helpful resources for you there. All right, Ashley, we've got just a minute. I think I can take one more question. Again, if there were questions that were unanswered, we will be going through our chat and we will be sending a follow-up document. So please rest assured your questions will be answered. All right, Ashley.
All right, I think we had just a couple more come in. Let me take a look though. We had one more come in that says, for an inpatient, place of service 61 or 21, or do we bill place of service 02?
So if the service was telehealth, it's going to be where the patient is. So if the patient was inpatient and you're billing that inpatient, then it's going to be an inpatient service. This is going to be how that service is billed. It'd be just the same with a skilled nursing facility. So it just depends on how that patient is classified. If they're classified as inpatient, it's going to be an inpatient. If they're outpatient, it'd be that 02 or that 10. And Ashley, I think I do have to wrap up, everybody. So thank you again for all of your questions, the pre-submitted questions, the ones in the chat. Again, rest assured we are going to get answers to all of those. But I do want to be respectful of everybody's time. For questions also, if you have any additional questions that you didn't put in the chat today, that is okay. We are taking additional questions for the next 7 days, and you are going to see an email here shortly. That is going to be our education mailbox where you can submit those. One ask, again with that subject line, make sure you're getting telehealth in that subject line. That's just going to let our teammates that are monitoring that mailbox know they've got to get that to myself and Ashley so that we can get you the answers to those. All right. So to wrap up, in a few minutes, you will receive an email that's thanking you for attending. Don't delete that without taking a look at that. It serves multiple purposes. First, it is your certificate of achievement if you're looking for continuing education credits. We do not issue CEUs. However, the various accreditation and certification boards do recognize our sessions for credit towards those hours. So that certificate of achievement can be submitted to your accreditation or certification body for those CEUs. If you did not get that, one of two things happened. You attended by phone, and I don't have a systematic way to verify your attendance, or went to your junk or spam folder. In either case, go ahead and send an email to that education mailbox, letting us know you need a certificate and the phone number that you attended from. Once I verify your attendance, I'll go ahead and get a certificate out to you. Also in that email, you are going to have the opportunity again to provide us feedback. Tell us how we did, how we could support you better. And again, this is also an opportunity for you to provide in the comments suggestions for topics that you'd like to see in the future. A couple ways to take it. It is in that email. There's going to be a link. You are going to see that it actually has added a link to the survey in the chat. You can click on it. It'll take you right out there. Also, when you leave, you are going to get a pop-up. We just want to make you aware of that. That's not malicious. That's not spam. It's not taking you anywhere you don't want to go. It's just letting you know you're leaving our webinar software and you're going into CMS's Qualtrics survey software. So again, I'd like to thank you in advance for taking a few minutes. I look forward to looking at reviewing those comments and tailoring our education based on those. With that, that does end our session for today. I know telehealth has had a lot of stops and starts, so we appreciate you taking the time out of your busy schedule to try and level set with where we are in 2026. I hope you found today's session helpful, and on behalf of myself, Ashley, and the entire Provider Outreach and Education team here at WPS, I'd like to thank you for taking the time to attend. We look forward to seeing you in future sessions. Remember, we do have a session specific to mental health on March 19th, and that registration is still open. Also, we have Ashley's interactive session tomorrow on denials and rejections for telehealth, so the story's not over yet. Again, we hope to see you. You may now disconnect. Have a fantastic day.